With all the evidence of heart surgery, mental health, yes, it's close to my heart. With all the evidence of heart surgery patients suffering from PTSD and anxiety, is there going to be mental health support going hand in hand with medical treatment in the future? I hope yes. That's a short answer. So the evidence right now is that there's a good manuscript that has just been out from a team of Boston saying that there's up to 2/3 of the adolescent patients who have a single ventricle who at the time of the adolescence have some form of psychiatric disorder. Don't get excited. It may be very broad and wide, and it may not be, anything of significance or seriousness that you would consider. And it's coming from the team of Boston who have referral from absolutely worst case throughout the country in the US. So they may have a selected population that is sicker than what you would imagine. The numbers in Australia and New Zealand, the preliminary number is that 27% of the people have some degree of anxiety or depression that would need attention, psychological support, which I would believe in the majority of the case they're not getting. So seriously, there's something to be done. We can do much better. And as the question mentioned, I think really by discussing with families that the time at which we should do something is at the time of the first diagnosis. The first contact with the hospital medium, the first contact with the disease is the most important one. And the people, you can discuss with people, they seem to suffer sequelae 10, 15, 20 years later from their first experience with the medical treatment of their child. And so that's the time where something should be done. I think I can feel that in the hospital here and worldwide, there's a willingness to tackle that problem. And it's stupid not to do it, because it changed enormously the life of the families. It changed the patient satisfaction, the consumer experience, and it's cost nothing. I mean, it doesn't cost nothing, but the care of a patient who has a Fontan costs more than $300,000 until they get to the age of 18. Adding up psychological care would add $1,000, $2,000 would already be enormously efficient for each patient. That's nothing compared to all what we invest in these people, and the benefits would be enormous. We're doing also a work now in the adolescent patients. We want to support the people psychologically because we believe that that's a time where we can screen them easily because we are building up a better transition process. And we could be quite efficient at that time. That's the project that we have now. Do you believe early intervention would be beneficial to patients and families in terms of mental health? I think I've just answered that question. There's a work that's being done in the MCRI that is beautiful, where there is a study with families participating to webcam conversation with a psychologist. Can you imagine? So they're having up to 8 families with one psychologist, and that seemed to have benefits in terms of well-being for these families. I mean, how much does it cost to have one psychologist for 8 families at the same time? Not much, I think. That seems like a very, very good idea. What time of follow-up? What time of follow-up care is recommended for people with a Fontan circulation? That's the million-dollar question. We don't know yet. I can tell you that there's an international group that is working on the questions to make preliminary recommendation. I can tell you what we have agreed for in Australia and New Zealand so far, and we're still working together to have a recommendation. We agree that patients with a Fontan circulation should be seen once per year or per 2 years at least by a cardiologist. We agree that examination at this stage should still include ECG, echocardiography, and likely some blood tests to test the liver and the renal function. Which blood test, we do not completely agree yet. We agreed that at the time of the transition between 12 and 14 years of age, we should proceed with an MRI, with an exercise study, and for the time being, and we may decide not to do it in the future, to a Holter monitoring, to look at the heart rate for a period of 24 hours, 48 hours, a bit more. In the adult world, most of the people nowadays will do on regular interval exercise study to monitor the quality of the circulation, how it's working. They will do, most of them, not all, Holter monitoring, and they will do on regular interval MRI, more or less every 5 years. There's no agreement yet, but that seems to be the trend in most of the adult centers, not all of them. I personally believe that at some stage you should check what guys like me, surgeons, are doing. You're trusting your life in the quality of the Fontan circuits. I think it's super important. Personally, we should look at it, have some good imaging by MRI or cath within a year of the completion of the Fontan. But that's a personal opinion, and we do not have that agreement in Australia and New Zealand. With the growing evidence of liver issues, fibrosis in Fontan patients, what is the treatment for this? Can you still have a transplant? Do you transplant both the heart and the liver? We do not yet have a treatment for liver cirrhosis, but it's likely it's driven by high pressure in the veins. So if you want to tackle this issue, we have to tackle that. And I believe that if you have a heart transplantation, your problems with your liver will improve. My thought is that in the distant future, if you have machines, maybe to help the circulation of the Fontan, maybe that will be an indication. Using a machine, at least intermittently, just to help the liver and relieve the fibrosis of the liver. There's experimental work that has been done with some friends and colleagues from Philadelphia looking at the interest of spironolactone in these drugs. And there's some drugs that are specifically targeting fibrosis in the liver and apparently are efficient in other circumstances. Whether they're efficient in the Fontan circulation is unknown, but I think we will have some trial of that in the future. Can we still have a transplant? Yes. And I believe that there are more fibrosis than liver dysfunction. So compared to people who have liver fibrosis because they drink too much or because they have hepatitis, viral infection, their liver function better for the same amount of scar tissue or fibrosis that you have in the liver. So they can have more heart transplantation than some team or people believe, I think. Do you transplant both the heart and the liver? Only a very few teams have done that. And one of the only few teams who has done heart and liver transplant is backing off from that strategy. So I have, discussing back with colleagues, I have been saying that they've tried that, and I don't have the details of why they're backing off, but they don't think that's the ideal thing to do. As Michael mentioned, as time goes on for Fontan patients, there appears a growing number of liver and kidney issues. In your opinion, is there enough statistics on this to warrant a mandatory or at least a strict process of regular ongoing screening of Fontan patients? And the bracket, some patients are not told of this issue, and I recently witnessed for one family it was too late, and the mother was shocked that kidney liver issues were never mentioned. In our medical community, we have starting to talk about liver issues in the last 5 years, in the kidney issues in the last 5 years, but very little. So there seems to be growing information, but very little. Liver issues, the people agree now that we have to follow that up. So if you have a Fontan circulation, your liver enzyme, the easy things to check in the blood should be checked. Something should be done to investigate and look at the liver. The important thing is that you can have scar tissue, and if you have scar tissue, that's a field for generating liver cancer. Super, super rare. The people are talking and like to talk about it. If you read in the literature, you can read that. It's extremely rare, and it's not getting into a problem right now yet. It may become that in 10, 20 years, but that is not the case now. But still, you should check it, because that may influence your decision. If your Fontan is failing, you may want to consider a heart transplantation before your liver is too damaged. Kidneys, the people argue, yes, but kidneys, we see that there's a problem, but it's not a big problem. True. It doesn't need to be a big problem. They don't seem to fail because of their kidneys, and we don't have solutions for that. Does that mean that we should not follow the kidney issues? Well, I don't think so. If we end up finding out that some patients will hit the wall because of their kidney dysfunction, the people will say, you've known that for 20 years, why haven't you done anything? Why have you studied it? If we suspect that it may become a problem and something may be done to it, then we should study it. So I think that it's so easy to find out whether you have any kidney impact. I think you should test it. At the end of the day, the more information you have on the Fontan circulation, the more information you know on how your Fontan circulation is working. The more information you have from the whole piece, the more you have a correct overall picture, rather than looking just at one thing. Most of the time you go to your cardiologist, you look at your echocardiography and your ECG, and you talk a little bit. And if your cardiologist is, a good one, you check is your saturation. It's not always the case. This ECG and this echocardiography do not tell you much about your circulation. It's likely that your liver function, your kidney function, whether you have decreased lymphocyte counts, white cell count, is a better indicator of how your Fontan circulation is working. So I think you should check. And then, if there is any studies that is done to improve this liver dysfunction, this kidney dysfunction, then you can participate in it. There are some drugs that are universally good for kidney dysfunction, and it's ACE inhibitor, that we have talked about already. So the drugs that dilate your arteries, they're targeted for the kidneys, for the kidney to work better, and they may work in the Fontan circulation. They should be tried. And this issue should be discussed by the cardiologist, I think, with the patients. Many people with the Fontan circulation suffer from migraine and leg cramps. What is the thought as to why some people have this side effect? What can be done for people experiencing this effect? It would make sense that you have migraine if you live with high venous pressure. You just have to hang by your foot, head down, to know that after a few minutes your head is starting to burst slowly. So if you have 4 or 5 times the normal pressure in your veins, why would you not have migraines? Is that a big problem? We don't know. We are currently completing a study, so in about 6 months, I should have the answer to that. Leg cramps, again, when we look at the survey, that did not seem to be a large concern. Some people have described it, and it could fit with the fact that your arteries in your limbs, as I mentioned, are a little bit tighter. What to do? I don't know about it yet. Do you think there is a need for standard guidelines of care follow-up to be established to monitor for potential change in people with Fontan circulation? How often do they should they have catheter, MRI, bone density, liver, kidney testing, echo, ECG? Undoubtedly, we need recommendation. We will build up international recommendation, or at least orientation of this, what should be done soon. And we will do that work in Australia and New Zealand in about 1 to 2 years' time. And it's not going to be perfect, but it's going to be a first work. That work is being done now. It is well understood that many people with Fontan circulation that have a poor quality of life due to their health will benefit from ongoing allied health services involvement, although most families experience that after their child has had surgery, that these services are no longer available to them. Are there plans to incorporate this into standard of care for these people, or is it dependent to the center hospital you attend? For the time being, it's very dependent on the center and the hospital you attend. But there are work being done in that field. Heart Kids is working on that, and I think I count on them to help us. If the say that the CEO of Heart Kids was saying is that he was working for pulmonary disease and cystic fibrosis before, and the good example is a family who had a patient who had a kid who had cystic fibrosis, and another kid who had a frontal circulation. The kid with cystic fibrosis had all the allied health costs of care covered by NBS scheme or other scheme in the country, and the kid who had a heart problem had nothing. That's not normal, and that should be changed. And I think that in the best position to have that political change, because it's a political issue.